Hello. So I think we'll kickstart. I'll just say a few words and then Shona can take over and then Mary can. So I think good evening, everyone. Welcome to this breast support group meeting. We started these meetings mainly to address issues that you may have, and I can see a lot of you have joined. Please tell me, we have this meeting usually on Mondays, the third Monday of the month. If you would like to discuss something next time, please let me know. I've had some requests to talk about prebiotic and probiotics, so we may take that. And also had a request to talk about BRCA testing once again. So we'll take that down the line. The reason we are talking today is there are a lot of issues relating to the underarm surgery or the axillary nodal dissection, whether you've had, how many nodes you've had removed, whether you've had a sentinel node or an axillary dissection, and what implication it has for you immediately or lifelong. And it is a pleasure for me to have Mary, who I worked with at the Royal Marsden, and Manjusha from Tata Hospital, who will take us through. I'll hand it to Dr. Shona Nag from Pune. Shona, you are on. Can you hear me, Shona? Is Dr. Shona on?
Is that better?
That's better. That's better. Sorry, my voice was a bit low.
No
ahead,
problem.
Shona. Yes.
So thank you, Bhawna, for that, and welcome to you all to this very nice support group on lymphedema. It's a question we clinicians get asked a lot in the clinic, and it's nice to see a lot of familiar faces here. So we have a real treat with Mary Woods talking to us first. She's a nurse consultant for lymphedema at the Royal Marsden in London. And this will be followed by a talk by Manjusha. And Manjusha is in charge of the occupational therapy department at the Tata Memorial Hospital. She's been extremely helpful to us. And I think we can take our questions after both these talks. So Mary, over to you.
Good afternoon. Well, I think it's good morning to say to you. It's afternoon here. We've got a very bright sunny afternoon here, which is lovely. We're expecting winter to arrive any minute, but for the moment we're enjoying the sunshine. So thank you so much for inviting me to speak with you today. Can you hear me?
Yes, ma'am.
Is that okay?
Yes.
Okay. So my name's Mary Woods, and I'm a nurse consultant in the lymphedema service at the Royal Marsden, and it's a post I've been in for quite some time. I'm passionate about lymphedema, with breast cancer related lymphedema particularly, but we see a range of patients with lymphedema for a number of tumour groups. So I'm going to try and work my way through this session with you. Please do feel free to ask questions as we go along. I've aimed it primarily, I believe, at patients, for people who are at risk of lymphedema rather than healthcare professionals. Is that correct? Or are you all mainly healthcare professionals? Have I got that wrong?
No, it's mainly patients, Mary.
Okay, that's fine. Thank you. So let's see how we get on here. So I've structured this session around these areas. I'm going to talk a little bit about what lymphedema is and how we recognise it. Then I'll talk about why you're at risk and how to minimise the risk, and then touch on what to do if you're worried about lymphedema being present, and that'll cover some of the treatment strategies as well. I believe we've got about 45 minutes, is that correct?
So
Yes,
about, I think, 25 minutes to talk and then questions, and then Manjusha will talk for 15, 20 minutes.
Okay, that's fine. Okay, thank you. So first of all, what is lymphedema? So this slide has got 4 areas to it. Lymphedema is chronic swelling. It's swelling which occurs when lymph fluid cannot drain in the usual way through the lymph channels or nodes. Now, when I'm talking to patients, I often liken it to a river that's moving in one direction, because the fluid is moving. Lymph fluid only moves in one direction. It's not circulatory like the blood system. It's just in one direction. And if it comes across some blockage or some damage along the way, the fluid can't drain effectively. So it begins to spill over into the tissues, and that's when swelling becomes visible. The second point is that it can occur anywhere in the body where lymph drainage is compromised. So I mentioned earlier about numbers of, groups of patients who've had cancer-related treatment, and lots of patients that we see have some of their lymph nodes removed or irradiated. And that's when lymph drainage can be compromised. And in the group that we're talking about today, the breast group, it's primarily when the lymph channels in the axilla or the breast area have been interrupted. Now, there's two terms for lymphedema. If patients have treatment for cancer, which involves some of the lymph nodes being removed, that's called secondary lymphedema, because it's occurring after something has happened. But there is a group of patients or group of people who have a congenital abnormality, and that's called primary lymphedema. So it's important the two aren't confused. This is a very busy slide, and I'm not going to go into it in too much depth, but it's really just to highlight that the lymphatic system is a one-way drainage system, and there are lots of lymph nodes around the body which converge on deeper channels and then drain the lymph fluid. Oops. So how many lymph nodes do you think you have in your body? Now, it's going to be difficult for you to answer this question so that I can see your answers, but have a little think about that and maybe make a note of what you think the answer might be. And I'll just count in my head to 10 while you do that. So the answer is 400 to 600. Sounds an awful lot, doesn't it? And the majority of those are focused in the head and neck region, interestingly enough, but they are interspersed all around the body. So we'll move on now to why there is a risk of the development of lymphedema. And at this point, I'm going to re-emphasize the fact that some of the lymph nodes may have been surgically removed or irradiated as part of the breast cancer treatment. And this can interrupt the drainage of the lymph fluid from these channels in the axilla and moving across to the breast area and along the neck area as well, which feed into these lymph channels, and swelling can then develop. So where does the swelling develop? Well, it primarily can develop on the side of the body that's been treated for breast cancer. So that can be in all or part of the arm, and that includes the hand and the fingers. And it might be that it's just one part of the one part of the arm. So it might be the forearm, it might be the upper arm, it might just be the hand and the fingers that are involved, or it might be the whole of the arm. So it does vary considerably between patients. And we also see a large number of patients who have lymphedema in the treated breast. And that sometimes gets overlooked because swelling is usually thought to develop in the arm, but in fact, the breast itself can become swollen following treatment for breast cancer. And that can be quite distressing for patients. So is all swelling lymphedema? It's often confused as to when swelling becomes lymphedema. Is it straight after surgery that it's likely to happen? Is it later on? There's been some research done to suggest that a period of time needs to elapse before swelling that might be present is called lymphedema. But this slide tries to just identify the different phases of swelling. So immediately after surgery, there may be some acute swelling, and that's a normal response of the body to an injury, in this case surgery or radiotherapy. The body sets off a reaction, and that usually resolves in a few days without any treatment. It's just the body healing itself. Now, inflammation is also a type of swelling, and that can develop after surgery. And you may know this as cording or axillary web syndrome. And that can feel like there's a tight cord along the length of the arm. And there may be some associated inflammation with that. And again, with time, that usually resolves. And some gentle exercises can help with that resolution of that swelling. And of course, we'll all be familiar with trauma. So any damage to the skin, any insect bites, stings, damage to the skin is called trauma. And again, the body heals itself spontaneously when that happens. So does that answer, I'll just go back one again, does that answer the question about whether all swelling is lymphedema? I think it's important to allow time for any acute swelling to settle. And if swelling is still present after a period of time that may be just a few weeks, we would then be thinking perhaps this is more than just acute swelling, and whether we need to be a little bit more mindful of whether that needs some further treatment. So just some questions now. And you may want to just again jot down the answers that you think may be related to this question. Does lymphedema usually develop immediately after breast cancer treatment? Is that true or false? And the answer to that question is false, because lymphedema can develop weeks, months, or even years after treatment for breast cancer. And the next question is whether 50% of women get lymphedema after treatment for breast cancer. Do you think that's true or false? And the answer to that question is false, because we know from research that approximately a third of women will develop. The other quarter of this circle I've already alluded to, that approximately a third of women develop lymphedema after breast cancer. So how do you advise people, or how do you as patients minimize the risk of developing lymphedema? So there are two key points here: the avoidance of infection and the avoidance of inflammation. If we just focus on infection just for a second, because the lymph nodes have been removed, and remember the lymph nodes and the lymph channels play a very important part in fighting infection in your body, the risk of infection is increased. Now, it's only in the area where the lymph nodes have been removed. The rest of the body has functioning lymph nodes unless something else has happened. But generally speaking, the lymph nodes in the area that have been, where these have been removed, the area associated with that is the area where the infection risk is present. Now, inflammation can happen if the arm is overused. And we'll talk about that a little bit more over the next few slides. So tips for reducing lymphedema, or reducing the risk of lymphedema. Exercise. It's so important to keep going with muscular activity and general exercise. Now, some of you, if not all of you, will have been taught some hand and arm exercises to complete at the time of your surgery or during your radiotherapy. And what we find with our patients is that those exercises tend to be forgotten after a little while. Perhaps life gets back to a bit more of normality and the arm appears to be quite mobile. It doesn't seem to be any particular problems. But those exercises to maintain joint mobility need to be carried on for the rest of your life, to maintain mobility, to maintain lymphatic function. And obviously some of you will have some particular exercises or sports that you're familiar with, and it really is important to return to those, but you might want to return to them using a phased return, so a gradual return and building it up gradually. Weight management is also important. The risk of lymphedema does increase if body weight is above normal limits. Now, I appreciate that sometimes it's difficult when breast cancer treatment, particularly hormonal treatment, goes on for a number of years after the initial surgery and radiotherapy, but by trying to keep the weight within normal limits, maintains lymph function and actually minimises the risk of lymphedema. And the third part on this slide is about avoiding the use of the arm for blood tests and procedures. And the aim of that bit of advice is to minimise the risk of infection and to protect the smaller lymphatics. So there's been quite a lot of debate over whether this is important or not. And our advice is that if there are functioning veins and easily accessible veins in the opposite arm, these should be used for any blood tests, any procedures, anything going in the arm, anything coming out of the arm. It obviously is difficult if someone has had both sides treated and both sides are at risk of lymphedema. And in that situation, there needs to be a risk-benefit analysis taken and, you know, trying to decide which of the arms is least at risk, or using some of the veins in perhaps the feet, which can be accessed. I suspect we might talk a little bit about that with some of your questions. So the next slide, this focuses a little bit more on the risk of infection and obviously keeping the skin in really good condition, keeping it healthy, keeping it intact, making sure that there are no dry areas, no flaky areas, no breaks in the skin, no trauma to the skin. This reduces the risk of infection. So some things to think about here are activities around the home, making sure that the skin is protected, making sure that pets don't scratch the skin, and should any trauma occur, it's important to use a good antiseptic to just protect the skin and just, you know, reduce that risk of infection. If there's a chance that there may be some insects around or some bites that may happen, using a good skin protector, using a good insect repellent, using a good sun protector in hot weather also protects the skin and again reduces the risk of infection. Now the inflammation side of reducing the risk of lymphedema, this can happen if the arm is used for sudden, strenuous, repetitive type movements. It's a little bit like perhaps if you suddenly do something with muscles that haven't been used for a little while, the muscles give you that ache the next day, and that's basically inflammation because those muscles have been overused and in a sudden fashion. So by thinking ahead and avoiding heavy lifting, heavy, strenuous, repetitive type movements, the risk of inflammation is reduced. And you know, again, things happen in daily life and muscles do get used suddenly, but by trying to think ahead, it can play a big part in reducing the risk of lymphedema. Sometimes when swelling appears, it's a little bit like a bruise. If you knock yourself, the next day you notice the bruise, and by then you've forgotten what you did that caused the bruise in the first place. And it's a little bit like swelling. If swelling does appear, it might be related to something strenuous that happened the day before or even the day before that. But by trying to think ahead and minimize those activities, it can go a long way towards minimizing the chances of swelling appearing. So another couple of things to think about. Is it true or false that lymphedema only develops in people who have had an axillary clearance? I'll just give you a second to think about that. The answer was in my presentation a few slides ago. And the answer is that it's false. The risk is present after any intervention to lymph nodes areas. Someone I think is writing on there. So the next one, is this true or false? You cannot travel abroad if you're at risk of lymphedema. And the answer to that question is false as well, because if there are precautions taken to minimize the risk of infection, there's no reason not to go abroad. So things like a skin insect repellent, sun cream, by actually taking some antiseptic, you know, to make sure that any broken areas of skin are treated. There's absolutely, I mean, at the moment, obviously nobody's going anywhere, but when we return to some form of normality and we're able to travel abroad a little more easily again in the future, there is no reason why lymphedema should be a factor involved in that. And then, is it true or false that you should avoid blood tests in the at-risk arm? Do you remember we talked about that just now? And the answer to that question is it's true. We want to avoid blood tests in the at-risk arm in order to minimize infection and preserve lymphatic function. So utilizing the veins in another arm, the opposite arm, or even the feet is preferable. And one final question on this slide. Is it true or false that people at risk of lymphedema cannot do Pilates or yoga? And the answer to that question is false. It's absolutely okay to return to activities that are enjoyed, which may include Pilates or yoga. But what is important is to avoid putting body weight through the at-risk arm for a prolonged period of time, and working with the instructor, making sure that the instructor is aware, or that you're you know, just taking a few precautions there. I can see that some of you are answering that question on the screen, so thank you for that. Okay, so we move on to the next slide. Okay, so how do you know if you might have lymphedema? So one of the first early signs that have been reported widely in the literature is an ache or a heaviness in the arm. So at this point, there's no swelling, but the arm might just feel as if it's heavy or it's aching. And again, if you try and think back to what might have caused that, was there some activity a few days ago or even the day before that was a bit more exertive, a little heavier than normal, and maybe modify any activities that were carried out in the preceding days, and just try and rest the arm a little bit more. So then the early symptoms of lymphedema might be some swelling, which is mild, and it may go away. It might be there for a little while, and then it may go away and settle overnight quite spontaneously. And this might happen on a couple of occasions, but it is an early symptom and it is a warning, and it's important to think about what might be happening and why that swelling has appeared. So thinking back to what's happening with the arm, thinking whether there's anything that needs modifying at all, and whether that swelling could be influenced by just adjusting activity. And this third box on this slide, I think it's important to remember, well, it's very important to remember, that lymphedema isn't normally painful, and equally it doesn't cause a change in function or sensation. So lymphedema following treatment for breast cancer due to intervention in the lymphatics is normally painless, and there isn't a change in any of the sensations or function of the arm. And if there is any change in sensation or the arm is painful, it really is important to seek some advice from your medical provider, from your medical team. There may need to be some further investigations carried out. So what should you do if you're worried that you may have lymphedema? Well, resting your arm is an important factor. Try to think of some activities that may have been exertive and increased lymph fluid, and just modify any activity that may be exertive or strenuous. Remembering that lymphedema may appear in the breast, what also is important is to wear a good support bra, because if the breast tissue in the breast that's being treated is allowed to just be unsupported, then breast edema can become more persistent. But if the breast is supported with a really good bra, then it does encourage lymph drainage, and the fluid can begin to move away from the breast tissue. And it goes without saying that your medical team or healthcare professionals are here for you, and they're here to provide advice and help should there be any concerns regarding the presence of any swelling in the arm. So the key messages are to avoid infection and to avoid inflammation, and I think I've captured them on the next slide. So let's just look at this one first. Sorry, was that a question?
No, Mary, carry on. I think it was just a
discussion point. Okay.
Yeah.
So this slide I apologize again because this is a bit busy, but it's really to highlight the aspects of treatment for lymphedema that are used. And you'll notice at the top of this slide here, where I'm talking about skincare, education, and exercise, those three things are factors involved in minimizing the risk of lymphedema. So they weave their way through right from the start to where treatment is required for swelling. The two things that can sometimes be added, and are certainly one of them is quite important, is a compression garment or some form of compression. And what that does is encourage lymph to drain through the tissues by putting a little bit of pressure on the tissue so that the muscular activity is enhanced. And that has the effect of promoting lymph drainage and encouraging what fluid has accumulated to begin to drain. And then in the right side at the bottom of this slide, I've talked about manual or simple lymph drainage. And this is a skin type of massage, skin movements on the skin to actually help lymph to function, or lymph to drain rather. And that manual lymph drainage is usually provided by a specialized therapist who's skilled in providing those movements on the skin. But a simple form of those is often taught to our patients so that they can be continued at home. And this is particularly important where there's some swelling in the breast, because some simple lymph drainage in the breast tissue can do a lot of good in encouraging the lymph to begin to drain. So in summary, following breast cancer treatment, there is a risk of lymphedema, which is present for all women who've had treatment for breast cancer. And I shouldn't say just women, because sometimes men get breast cancer too. So all people who have had treatment for breast cancer. So early advice and education is really important. And the aim there is to avoid infection and to avoid inflammation, because both of those two factors can encourage swelling to develop. And should swelling develop, the treatment strategies employed at an earlier stage, as early as possible, there's a range of different strategies. There's no one part of treatment for lymphedema that's important. It's a range of strategies all working in combination with each other. And they should be, hopefully skincare, exercise, weight management, and moderate use of the limb should be already being used, but there may be some additional interventions if swelling does begin to accumulate. Okay, so I'm sure there are lots of questions. Hopefully I'll be able to answer some of them for you, and I'll hand over back to you.
So I've summarized a few, Mary, some questions. So one of them is laser treatment helpful in treating lymphedema?
So we don't actually use laser in our practice here, but there are lots of services that do. And I think there's more evidence now for the use of laser, but we were very cautious about using it because laser does actually, to a certain extent, destroy some tissue. So there was a little bit of concern that whilst it might appear to improve the situation, what were the long-term effects of it? And there is more research coming out now to show that laser can be helpful. But I can't honestly say that I have used it and I would support it because I haven't used it. But I do know that it is used by a lot of therapists.
And the other question is, 10 years later, can patients have an IV line on the side of axillary dissection?
It would be preferable not to have any intervention in that arm for the rest of their life, because the risk of lymphedema is lifelong. So if there are other veins that can be accessed, it would be preferable for them to be accessed even 10 years or 20 years later.
And one of the other things, our patients, you know, the hot weather, the compression sleeves are very uncomfortable, and I find it quite hard to convince patients to keep it on. So what would be a good strategy to manage that? I mean, and how long should they keep it on? Should they keep it on when they sleep? I mean, what should we advise?
So we've got a few hints and tips about that. What we have found, because we've just had some really hot weather here as well, and it has been difficult, and I'm sure, you know, when the temperatures are really high in India, I'm sure it's extremely hard to wear a sleeve. What we advise patients to do is to put the sleeve in the fridge, cool it down, and then it can be easier to apply. Now, if it's impossible to wear when the day is hot, to try and wear the sleeve for part of the day. So if it's a little bit cooler in the morning, a little bit cooler in the evening, those are the times to try and wear it, or wear it overnight. But it's better to wear it for part of the day or overnight than to abandon it completely. Because if it's abandoned completely, there's a good chance that the swelling will accumulate, and then it's more difficult to get back on top of it. So wearing it for part of the day or overnight are things to perhaps aim for if it's impossible to wear it all day.
Great. Shona, do you have any that you've noted down?
There's one that's talking about itching on the side of the surgery 6 months later on the chest wall. So I don't think that's really related to lymphedema, but
no, yeah, that wouldn't be related to lymphedema. It may,
right.
Yeah, that there's some irritation for another reason.
Absolutely. And you also mentioned, Mary, that even sentinel node carries a small risk for lymphedema. So what can you quantify this risk?
No, it's very difficult to quantify a risk of lymphedema because obviously the risk is lifelong. So
right.
It's difficult. I hesitate to put percentages on risk or on incidence.
No, but like you said, 1/3 of women at risk after an axe dissection or surgery or radiation would develop lymphedema during their lifetime. So what would the corresponding incidence be after sentinel node? Are there any figures for this?
So I'm not going to be able to give you figures on that, but I will say that the risk is there and therefore the advice should be followed, but the risk is less because it's only one or two nodes rather than perhaps a number of nodes that have been removed.
Right.
Axillary dissection. But I still think it's really, really important that risk is addressed and patients are aware of that risk so that they can follow simple guidance to minimize the risk.
So would the precautions for that hand be similar to what you've talked about? I think that's very important for us.
Yeah, absolutely.
We tend to relax after a sentinel node is done. And some people even use that hand for interventions, but that's a complete no according to you, right?
Yeah, it's best avoided. The risk is still there, and we're aiming to minimize that risk as much as possible.
Yeah.
Wonderful. Mary, we have more questions, but I think we'll move on to the second talk with Dr. Manjusha Vagal. She's from Tata Hospital. Thank you so much, Mary. Wonderful.
Thank you.
And there's a request for your slides, but I'll email you later about that.
And, okay, that's lovely. All right, thank you. Thank you for inviting me. Bye-bye now.
Thank you so much.
Thank
Wonderful.
You.
So Manjusha, welcome. And we are looking forward to your talk because I think your experience in India is the most, and you would actually truly see the really refractory lymphedema, and we have some questions on that.
Oh my God, yes. So Dr. Bhawna Sirohi madam and Shona Nag madam, first of all, thank you for this invite. And it is an absolute honor and pleasure of mine to be here on this online platform of global support group meeting. So as suggested to me, I'll be speaking majorly on the India specific issues and challenges related to lymphedema and lymphedema management and lymphedema prevention. So should I begin?
Yeah,
I have
please.
got some slides. I would be presenting my slides.
Just share the screen. I think you should be able to. Yeah.
Okay. So, so as I said, I'll be speaking essentially on India-specific issues and challenges pertaining to lymphedema prevention and management. So these are the statistics. So in general, we get referral. Some more than 500 new upper limb lymphedema patients are referred to us annually, and some more than 2,500 follow-up patients we see. And for lower limb lymphedema, it is more than 100 new and more than 500 follow-up patients annually. Now, this referrals come from TMH OPDs as well as from private hospitals, or even patients directly contact us. And after they make TMH files, we start attending them. So at the time of the referral, most of our patients present with us with stage 2 lymphedema and including late stage 2 lymphedema as well. These patients also present with stage 3 and chronic lymphedema as well. But we do get stage 1 lymphedema also. But majorly it is stage 2 and late stage 2 patients we attend. Now, as Mary has briefly talked about what is a complete decongestive therapy or comprehensive decongestive therapy. So I would like to go a little bit in depth because I think Mary has not went into, I mean, she did not go into the depth. So just to make you understand, complete decongestive therapy is a two-phase management. So phase 1 management is also called as a treatment phase or a reductive phase, where the aim is to reduce the volume of the limb as much as possible. And phase 2 is the maintenance phase, which is a lifelong phase for the patient. Now, there are 4 to 5 basic components of this phase 1 and phase 2. So this includes the skin and the nail care, then therapeutic exercises, positioning. Then in phase 1, it is manual lymphatic drainage, which becomes simple lymphatic drainage or self-lymphatic drainage in phase 2. While there is compression therapy in the form of compression bandages for 24 hours in phase 1, which becomes only compression therapy in the form of bandages during nighttime and daytime compression garments. And phase 1 is different from phase 2 essentially in the sense that it is managed by the therapist 4 to 8 weeks continuously as till the time the result plateaus. And the therapist attends the patient 5 days a week. Now in phase 2, it is entirely managed by the patients under the guidance of the therapist. So as I said, the skin care, nail care remains the same. Therapeutic exercises will remain the same. Positioning remains the same. Only the lymphatic drainage becomes simple or self, and the compression therapy in the form of bandages during nighttime and compression garments during the daytime. So now in India, what happens is, what we have observed is patients have certain constraints because majority of our patients are, they are outstation patients who come to Tata Memorial Hospital and they cannot visit us for continuously 4 to 8 weeks. Similarly, they belong to low socioeconomic strata and they cannot afford to come to the hospital every day for 4 to 8 weeks. Similarly, those patients who are staying away from the hospital, they do not have access to a certified lymphedema therapist. So they do not have access to complete decongestive therapy. Now, that's the reason we have come up with a practical solution, and that's what we are practicing from more than 1 or 2 decades now. So we teach the patients both phase 1 and phase 2 management at the very beginning. And we see to it that patients and their relatives have understood what it is and they follow it at home and they keep in touch with us whenever they visit to their parent OPD and or they connect with us for our guidance electronically, that is through WhatsApp and through email. We have also understood one important thing in this so many years of practice, that the therapist's prescription of follow-ups and patient's adherence to follow-up is very vital for showing improvement in the patients. And the reason is we get the opportunity to understand whether the patient is meeting the targeted goals and whether there are any issues which patients are facing, and we can correct those issues by means of this follow-ups. And of course, it provides an encouragement for the patients to adhere to the maintenance phase treatment. We also teach the patient, what is the program like? Like, we teach the patient phase 1 and phase 2 management. So phase 1 management, we teach for 1 or 2 weeks, that is 5 to 10 working days. And patient then administer this phase 1 management for 4 to 8 weeks. And then patients are also taught how to take their girth measurements, that is, they can assess whether they are showing any improvement or they are not showing any improvement, so that they connect with us. And we emphasize on the patients the importance of compliance on every follow-up. Now, this is the typical picture here of the lymphedema clinic. So we teach the risk reduction practices and the exercises in the group to the patients and their relatives. We, on one-to-one basis, we teach the patient the simple lymphatic drainage and how to bandage their arms. Similarly, the patient's relatives are involved in this training process, so that if patient happens to not understand anything or they happen to make mistakes in them following their treatment, the relatives are there to help them and guide them. So what I mean to tell you here is, what we practice here is, as I said, ideally CDT phase 1, it is manual lymphatic drainage, but what we are practicing is simple lymphatic drainage from phase 1, that is from the very beginning. So these are some of the pictures of simple lymphatic drainage. This is how the measurement lymph girth assessment is. So lymph girth assessment is done with the tape measure, and you can see in the picture, patients are also taught how to take their own measurements, so they can keep tab on their edematous limb. And this form is is provided to the patients so that they can jot down their records or their assessments, and they can forward it to us for our opinion. Now, I just want to brief you about the retrospective review of our reports which we did to understand the effect of compliance with prescribed follow-ups and persistence of lymphedema reduction following home-based CDT in breast cancer patients. So as I said, it was a retrospective review of 54 breast cancer patients with unilateral lymphedema after axillary dissection without nodal radiation therapy, and it was performed between October 2010 and March 2016. So we tried to classify the patients into 2 groups. Group 1 was the patients who complied to the follow-ups, and group 2 was the one who did not comply to the follow-up as requested by the therapist. So in general, group 1 patients were 24 patients and group 2 were 30, and group 1 patients made in the period of mean 20 months, some 18 visits to the department, and group 2 patients made some in the mean period of 8 months, only 4 visits to the department, follow-up visits. And this graph is to just understand in the group 1 patients, the lymphedematous limb volume dipped from 30% to almost 13% at the end of phase 1. And it was maintained at 11% at the time when we actually collected the records. So it was in March 2016. For group 2, if you see here in the graph, the volume reduced from just 20% to 18%, just 2% it dipped. So that was what we found, and we understood that patient's compliance to follow-up is very essential, and we must insist the patient to stay in touch with us. Now, what are the challenges we face? So the one important thing what we do not have is a robust surveillance program for our patients. Now, surveillance program is essential to understand or detect lymphedema at very early stages. Now, detection of lymphedema in early stages is essential because the management is very simpler, because lymphedema is in its early stages, the management is simpler, the outcome is better, and definitely it is a cheaper option for the patients. The second important thing is the surveillance program along with the educational thing. If you add educational program also, it helps in preventing lymphedema or delaying the development of lymphedema. So we are in need of this program. Similarly, it creates awareness amongst the medical professionals as well as the patients and the relatives about lymphedema and its importance for adherence. That's the value of surveillance program. Now, what is required to be done in the surveillance program is we need to carry out the pre-treatment assessment for every patient. Self-assessment should be taught to the patients. So especially for outstation patients, they can keep tab of how their lymphedematous or at-risk lymph is responding to day-to-day life, whether they need any specialized intervention or no. Similarly, education needs to be given to the patients about what lymphedema is, how they should monitor for the signs and symptoms of lymphedema. And similarly, the education on risk reduction practices should be given to the patients under the surveillance program. So this should be done in detail, and the team should be focused a separate team should be working on this particular program for at-risk patients. The other challenges what we find is the awareness issues amongst the healthcare professionals. We actually carried out a questionnaire-based survey to assess the awareness amongst the healthcare professionals about breast cancer-related lymphedema. So we included the oncosurgeons, the medical oncologists, radiation oncologists, the occupational therapists, physiotherapists in this survey, and we sent this questionnaire to some 800 clinicians, out of which only 125 responded to us. Out of this 125, just 90 responded in first mail and 35 responded through repeat mails. And not all responded attempted all the 20 questions. So this questionnaire contained 20 questions. Important to understand, not all the questions were attempted by the respondents. Similarly, what we found out from this survey was like only 5 medical oncologists out of 125. We had only 5 medical oncologists who participated in this survey. Just 6 surgical oncologists, 1 radiation oncologist, 87 occupational therapists, 8 physiotherapists, and 18 others, which included palliative medicine care clinicians and nursing faculty. So this is very sad. I think we need a lot of awareness about lymphedema amongst the healthcare professionals. Unless until they understand the value of it, this is not going to get transferred to the patients, and we are going to continue receiving most of our patients in phase 2 or stage 2 lymphedema. Similarly, from the survey, we also found that some 30% of the respondents they said they have lymphedema clinic at their center, while 70% said they do not have the infrastructure to attend to the lymphedema patients. This is again a big concern, and I request anyone who is listening this program and who has some authority to establish a lymphedema clinic or some sort of setup to address the lymphedema issues in our patients should start and do something for this. Now, what other challenges we face is the ignorance on the part of the patients. So we have found that patients who learn lymphedema management, they do not turn back or return to us for follow-ups for months and years together. And if you look at this picture, and the lymphedema therapist will be able to pick up this immediately. The patient is not wearing any soft padding inside. She's just draping the crepe bandages. It is not even the short stretch bandages which she's putting. So this is a major concern. Again, patient thinks that they have understood and they can manage lymphedema. It is not like that. Lymphedema therapists' guidance in between periodically is very, very essential, and the patients need to understand this, that they should keep in touch with the therapist for their management. Again, it is not that only uneducated patients behave like this. This particular woman is a teacher by profession, and you can see this soft tissue fibrosis developing in the hand. And in the adjoining next picture, you can see the functional impairments caused due to this fibrosis. And you can understand this is the dominant hand which is affected. You can understand the plight of this woman while she's carrying out any kitchen activity or any household work or her office work for that matter. This functional activities get compromised because of the ignorance on the part of the patients as well. We would like to see more of our patients having subclinical lymphedema or stage 1 lymphedema max. Another challenge is we do not have a provision of calling patients as per the need of any particular individual patient. Now, what is happening is patients usually report, because most of our patients are outstation, they are given reservations to re-see their parent OPD after 6 months or 4 months. It depends upon the individual OPDs or particular guidelines or protocol they follow. But we want the patients, since we are attending these patients, we need to evaluate the patients in between. And lymphedema is so dynamic. You know, if the patients are not following the management adequately, if they are not very stringent or strictly following the precautions or the guidelines, there is some rise or increase in the lymph volume. So it's very important that the assessments are carried out, and we need to, if for example, we feel the patient has not understood so clearly and we need to re-see the patients, there is no provision as such. So if you, if I have to frame it, I would ask the patient to be there, visit the department for training purpose at least 5 working days or 10 working days, depends how the patient grasps the training program. Then phase 1 management, as long as the phase 1 management is going on, patient should visit at least once a week so that we can assess how the patient are responding to. Of course, it is not being done, and we are keeping track of these patients through WhatsApp and emails. And if you ask me for phase 2, they should follow up with us once in 15 days, at least twice, then once a month, at least once, and then once in 3 months or 4 months, at least twice, and once in 6 months thereafter. So gradual weaning of the support of the therapist should happen for better compliance of the patient, especially better compliance to this long-term management. Other challenges what we face are the patients and family perception, participation in lymphedema management. So what do I mean by this? So the patients, what we experience is patients give priority to their family, to the housework and the office work. Their health, their comfort and their appearance gets complete backseat, which is a major thing and should not happen unless until woman or whoever is affected with lymphedema gives importance to her health or his health and takes adequate or follows the guidelines properly. We are going to get challenges in treating lymphedema, especially during the maintenance phase. And there are simple solutions. You know, patients can carry out their family work or household work, other work. The only thing is they have to follow some energy conservation, work simplification techniques or lifestyle adjustments, which are very simple and which we regularly teach the patients. To give you an example, we just ask the patient to plan their week's activity in advance, or they can plan days activity in advance so that they do not overexert themselves. Similarly, they can give intermittent rest to the at-risk limb or edematous limb, and they can still carry out their tasks which they have to. So this is something very, very simple, but needs to be followed by the patients for better compliance and better outcome, especially of the maintenance phase. The other challenges includes the non-compliance to home program, especially to the compression therapy. Now, compression therapy essentially means the compression bandages and compression garments. Now, these are indicated for improving the muscle joint pump that helps in faster evacuation or better evacuation of the edematous limb. But then what is happening, or what is seen as, these patients find this compression therapy as hindrance in their day-to-day activities. And what they do is they finish off their basic course without wearing the compression garments or compression bandages. And when they are resting, they wear it. So they tell us, Madam, we carry out our kitchen activities fast, and then when we are resting, we are done with our work, we wear the compression garments. And there they go do the mistake. And that's the reason why they do not show the desired outcomes which we expect to see from these patients. So these were, or rather the challenges which we experience. And I think these are the common challenges which even Mary is probably experiencing. And this is worldwide common challenges or problems faced by any certified lymphedema therapist, I think. And this is just my attempt to explain you what are the issues we face in terms of managing lymphedema, taking or preventing lymphedema development in our country. So questions, please.
Manjusha, thank you so much. This was actually wonderful. And it was really sad to see that you only had about a handful of radiation medical and surgical oncologists engage with your questionnaire. Very sad to see, but I think with these support group meetings, what me and Shona are trying to do is try and bring as many issues for our women which relate to them, so that, you know, which are important for after cancer treatment care. So I think we were going to have something about bone health, about prebiotic, postbiotic. I have Dr. Sareen also on this call here, and she's organizing. So, you know, there are some of us who are quite passionate about this. Dr. Sareen is organizing a dialogue with Luke Coutinho next Sunday.
Okay.
So, you know, those of you who are interested, I will add you to our group and I will put that also. So I have some questions for you, which are there. So, do the rollers work for lymphedema treatment or prevention?
What I understand is roller is something which you are manually, I mean, rolling it on the limb, right?
Yes, yes.
No, we do not recommend any of such sort of activities or things for lymphedema management or prevention. It may do more harm to the patient, and we do not recommend that. Actually, see, when you are the management, basically, if you understand the manual lymphatic drainage which we carry out, it's a very gentle technique, you know, wherein the pressure is very, very gentle. So with roller, there is a chance that you are applying more pressure, and you may damage the superficial lymphatics which are still intact and which are functioning. You might put the smooth muscles of the lymphatic vein, the lymphatic vessels into spasm. Otherwise, you may damage the anchoring filaments. So we do not advise any sort of what you have said for management as well as prevention of lymphedema. Definitely no, complete no for this.
And so post radiotherapy, how long will it take for lymphedema to resolve? So I think that's a very open question. It's very difficult to answer, I know. But
I will make you understand. The one thing is, there is no cure for lymphedema. The thing is, if you address it at its early stages, you can keep a good control over it. But it doesn't mean that the patients with stage 2 lymphedema, you cannot revert it to stage 1 also. You know, you can revert it, you can reduce it to maximum level, and the patients who are compliant to their therapy, this thing is very much possible in them. But to give you the period, like a particular months or days, that in this many days or months it will get resolved, it is very difficult to say. So it depends on how patient follow it. If the patient is very compliant and we are starting with phase 1 management, usually maximum reduction of lymph volume happens in some patients 4 weeks and some patients 4 to 8 weeks. So we can expect maximum resolution of edematous lymph volume in maximum 8 weeks period.
So there's another question. So I have this quite often actually in my clinic as well. So I keep insisting that, you must wear a sleeve or a compression garment, but I will see the patient in the clinic for chemotherapy and the patient would not be wearing it.
Yeah.
So, and the other thing is insistence on wearing a bra, I think, which Mary pointed out, that it is very important that the bra, that the breasts are well supported after surgery.
Yeah.
And so what do you have any suggestions if somebody is not willing to wear a compression garment?
Ma'am, actually you need to give a good education to the patient about what lymphedema is.
Counseling, yeah.
Yes, unless until they understand what lymphedema is and what is the treatment for it and how bad it can become if it is not managed properly. Unless until you give this information, they will not be compliant to the management what you're saying. But still it is seen that patients, even if you give 1 session or 2 sessions, patients will not be compliant to the management. And in that situation, what I have observed is they need to be repeatedly bombarded with this instructions. A good counseling should be repeatedly done to these patients on regular basis. And even the relatives or family members are very, very important to be present at the time of this education. So if they understand, at least if the patient gets involved in their household, or as I said, they give more importance to their household course than to their health. The relatives are there to help the patients or their mothers or their wives. Kindly keep aside this work and do something for your health, at least for 15 or 20 minutes. And please follow wearing compression garments. If this is coming, a good family support is there, following your good education, they will definitely comply. But yes, because of the climate and all, the compliance becomes a challenge in our setup.
So I think we have these information leaflets, but I think what the point I got today is, I think putting the pictures might help.
Yes.
Because the pictures are quite scary, if you do not address it at stage 1 and 2, for it to progress to stage 3, it becomes more and more difficult to treat actually.
Yeah.
So we will actually
a single picture is just sufficient. If you understand patient is very strong-headed, not listening, maybe we can go to more scary pictures, and lymphangiosarcoma and all, we can make patient aware of that. If they do not treat lymphedema appropriately and adequately, it might get converted or it might result in the cancer of the lymphatic system itself. So that education is important.
Great. So then can we recommend bandaging if there is restriction in movement or brachial plexus involvement?
Yes.
So
but the thing is, you have to be very careful. You have to be very careful because with compression therapy, what happens there, if it is not done adequately without any proper training, the patient might cause unnecessary compression and patient's vasculature may get compromised. And that's why we always tell at the time of bandaging, it's very at the first day only, we instruct the patients that the nails should be kept open so that the patients can understand that if there is undue pressure on it. So if you educate the patients on to understand whether it is it's compromising on the vasculature or the sensations are getting compromised, if patients fingertips become cold, that's indication that it's too tight and they need to loosen it. But we advise the patients not to loosen it immediately. We advise the patient to move the lymph. Now, when there is brachial plexopathy or something like that, then the movement is not possible for the patient, active movements, but then passive movements can be carried out and an attempt is made to loosen the bandage with movements. If it is still not happening, then we have to open and re-bandage the lymph. That is what is advised.
Brilliant. And one last question I'll take. I think then we'll stop because we can carry on. So can you do the lymphedema pressure treatment more than once a month? I think that was the question, if I've got it right.
Pressure treatment meaning what?
Yes.
The machine they are talking about?
I think probably the machine, yes. Let me just go. How many times in a month can one use the lymphedema machine?
It can be given on
or
daily.
Can it be used daily?
Yeah. So if their patients are attended on OPD basis, we give it for a week or 2 weeks, 1 hour every day. But then the vitals and the parameters needs to be assessed. Okay, and we need to understand the history of the patient. Patient should not be a case of unattended congestive heart failure, etc. So that you are not rushing in a lot of fluid in the compromised cardiovascular system. So that is one thing. And I mean, I have not actually understood the question. I perceive it is pertaining to the compression therapy, I mean, the lymphapress or
Lymphapress, I think so.
Sequential pneumatic pressure pump they are asking about. Yes, it can be, I mean, it can be given on daily basis for a week or 2, depends how the patient is able to take it.
Great. Thank you so much, Manjusha. I'm really grateful. I really enjoyed your talk, and I'm sure our patients did as well. And I'm really grateful to Riverroot, Nimesh, for hosting this meeting and helping us do this every month. So we'll meet again on the 3rd Monday in October. And there are 2 topics we have. One is prebiotic and probiotic, and the next one is bone health. So I think we're going to take up bone health next time and have an expert talk to us about that, and maybe a patient also talk about her experience as well. Thank you. Thank you. Thank you. Thank you, Nimesh. Thank you, everybody. Thank you, Manjusha.
Thank you.
Thank you.
Thank you, Dr. Bhawna.